Hi guys, thanks for joining us today, whether it's in person or virtually, and thank you for having me. Again, my name is Meredith Morgan. I'm a nurse practitioner. I've been taking care of prostate cancer patients for over a decade. Started my career in urologic surgery at Vanderbilt in Nashville, Tennessee, then moved on to Cornell in New York, and have spent the last 6 years at the University of Michigan in GU Medical Oncology. So what are we going to talk about today? Today we're going to talk about the physical and emotional side effects of prostate cancer, and sort of in the context of being a survivor. And then, what can we do? How do we live with prostate cancer amidst these side effects? There we go. So I just wanted to start with a quote from a ZERO participant. He said, "There are many men who think that they won't ever get prostate cancer, or that it isn't something they don't want to talk about. When I was diagnosed, it felt like I was standing on a football field all by myself. I got involved with ZERO and raising awareness because I wanted to help other men from feeling the same way." And so there is sort of a feeling of isolation, which is a common emotional side effect of prostate cancer. Having trouble advancing my slides here. There we go. Okay. And then another quote, "It is my passion to show other men that staying active can help you fight prostate cancer." So what are we going to do with living with cancer, and how are we going to make that work for us and help other people? And so when we think about survivorship, there's many different definitions of prostate cancer survivorship. And some individuals start their survivorship journey at the time of diagnosis, and others really define their survivorship after they are treated, and others are in the midst of ongoing treatment. So everyone's journey is different, and wherever you are in your journey, you have to know that you're not alone. There are 3.1 million men with prostate cancer today. And I just want to point out that survivorship is not just those that are cured or that are in remission or have an undetectable PSA. If you're living with prostate cancer, then you are a prostate cancer survivor and should include yourself in that group. I've heard a lot of people tell their stories the past couple of days, and I want you to sort of take a moment and think about where you were in the moment you were diagnosed. And I'm sure everyone remembers that moment. So picture yourself wherever you were when you got the news. Maybe you were in a urologist's office, or maybe it was on the phone at work or home. Maybe you were in an emergency room or a hospital setting. Maybe that was 6 months ago. Maybe that was a decade ago. But hearing those words, you might not have been able to absorb them or believe them. You might have had feelings of being overwhelmed. You might have had shock, feeling numb. Some men say they felt sad or angry. Others say they felt no emotion at all, maybe even denial if you had no obvious symptoms or didn't feel sick. But really, from that moment on, you're different. And so when we think about survivorship, it includes deciding your treatment, it includes your treatment, it includes beyond treatment. But really, being a survivor is how you are living after a cancer diagnosis. And so when we think about being a survivor and the side effects, it really encompasses so many things. There's the physical side effects. There's the emotional or psychosocial. There's the financial toxicity, which someone will talk about later today. There's the whole healthcare piece and all your follow-up. There's how your overall quality of life fits into that. And then we don't discount family members and friends and caregivers who really are a part of your survivorship experience. Another quote I found from the NCI, it says, "While cancer is a major event for all who are diagnosed, it brings with it the chance for growth. As hard as treatment can be, many cancer survivors have told us that the experience led them to make important changes in their lives. Many say they now take time to appreciate each new day. They also have learned how to take better care of themselves and value how others care for them. And others can draw from their experience to become advocates to improve cancer research, treatment, and care, which all of you are doing just by being here." And then I also hear patients talk about, my new normal. Another quote, "Many say that they felt they had lots of support during their treatment, But once it ended, it was hard to make a transition to a new way of life. It was like entering a whole new world where they had to adjust to new feelings, new problems, and different ways of looking at the world. And so men say after their diagnosis, they view themselves differently. They're viewed differently by other people. And so it's finding that new sense of self and how other people are looking at you and sort of learning how to live that way. And so I think the most common emotion that men feel when they're diagnosed is loss of control. It's frustrating for many men, especially if you've been independent or you feel like you're the one responsible for taking care of everyone else in your family. And so I'd like to talk about some things that are in your control. And this is a list that I'm just going to go through. So the first thing is healthy living. How do you keep yourself healthy, mind and body, and maybe even increase your chances of a good outcome in treatment, and maybe even decrease your chance of recurrence? So it's just taking care of your mind and body in the context of having prostate cancer. And so I tell my patients, don't smoke, limit alcohol, eat healthy, and don't discount the power of exercise. It can decrease anxiety and depression, it can improve your mood, it can boost self-esteem, and it may even reduce physical side effects like fatigue, nausea, pain, diarrhea, and even bone pain. And then what else can you do? Well, you can take an active role in your care. Well, what does that mean? That's knowing your follow-up plan and sort of knowing what are my frequency of visits. Am I coming in every 3 months? Am I coming in every 4 months? How does the first year after being diagnosed change for the second year or the third year or the fourth year? It's knowing who's on your team, so knowing who's going to follow you. Who's your nurse? Who is, other than your physician, what other providers might you be seeing during treatment? Will you see a nurse practitioner? Will you see a physician assistant? Why would you see those providers instead of the doctor in certain scenarios, and knowing those folks on your team. And then also knowing when you call your office, who are you going to be talking to? Obviously, you don't get your doctor every time. And so knowing all the players on your team is really important. And then taking an active role in knowing labs. We all know we're going to get a PSA, but what other labs is my doctor checking? A CBC, a comprehensive panel, and what are they looking for? And then imaging. What kind of imaging am I going to be getting? What are you looking for on imaging? How often are you going to image me? These are good things to know in your care. And then also to ask your doctor, what symptoms should I be worried about? What should I call you for? And then the genetics piece. It's part of your access to information. Unfortunately, it's not offered to every person. Sometimes you have to ask for it. But it could not only benefit you or your potential future treatment options, but it can also show the risk of cancer in your families. So how to, give more information to brothers, sisters, sons, daughters. And you can ask your urologist, your medical oncologist about genetic testing, and they may also refer you to a genetic counselor. Before I get into sort of standard treatments of prostate cancer and how that affects side effects, I do want to acknowledge that, there's complementary or alternative therapies. And I define complementary as sort of things we do with standard therapy, so in addition to standard therapy. I use the word alternative as a word to describe things you're doing in place of standard therapy. But many patients want information about this and sort of go outside of their healthcare provider to find these things. So dietary supplements, vitamins, herbal supplements, teas, acupuncture, massage therapy, spiritual healing called Reiki, meditation. And so these are things that you can look into and do. A little bit of a disclaimer here, natural does not always mean safe. And so it's very important if you're on an oral medication for your prostate cancer, you're on chemo, you're having surgery, or you're on a clinical trial, to tell your physician all of these additional non-prescription medications like dietary supplements that you may be taking. But they may help men, so it is worth exploring. And so when we think about treatment and how that affects side effects, most men are diagnosed with prostate cancer while the cancer is still confined to the prostate. That is your best chance for a cure. But those treatment options are not without complications. and possible side effects. And so when we think about all the treatment options for prostate cancer, starting with active surveillance, even not doing anything, even not treating your prostate cancer has side effects. So even men who choose active surveillance, they're going to be checking PSAs frequently. They're going to be getting rectal exams frequently, prostate MRIs, serial prostate biopsies. So even the decision to do active surveillance is going to have side effects, both physical and emotional. And a lot of my patients that are on active surveillance have a lot of anxiety. And that's because they feel like they're not necessarily treating their prostate cancer. And so I find that even the folks who aren't doing treatment can have physical and emotional side effects with active surveillance, especially that anxiety piece. And then surgery, as you guys already know, the biggest two side effects are urinary incontinence and erectile dysfunction, which we'll talk about. And with radiation, sort of some different side effects, but also similar: bowel or bladder dysfunction, erectile dysfunction, sometimes pain flares if bone is radiated. And then other treatments, hormonal therapy, oral medications, chemo, IVs, IV medication, that can all cause side effects, which we'll talk about. So surgery, I know all of you guys have heard of a robotic radical prostatectomy. Some of you may have had them, but the surgery definitely causes side effects. I mean, when you're severing the urethra from the bladder and making a new connection, there's lots of healing that takes place and lots of potential side effects. And I think one thing that surgeons don't always tell patients up front is that the extent of your disease and how big your prostate is, both of those things play into how much side effect burden you're going to get. So the bigger your prostate, the bigger risk of urinary incontinence after surgery, and then how extensive your disease is, the less nerve sparing surgeons are going to be able to do. So if you just have disease on the right side of your prostate, they may be able to do an A+ nerve sparing job on the other side, versus if you have pretty extensive disease on both sides of the prostate, they may not be able to nerve spare at all. And often those sort of decisions don't go into someone's choice to have surgery, but the reality is those things really affect the side effect burden afterwards. And then erectile dysfunction, going into surgery, whatever you're working with, it's going to be taken down several notches. And erectile dysfunction is defined as the inability to obtain an erection or maintain an erection, which we'll go into a little bit later. And then radiation, whether it's external beam or internal or a combination, side effects. Urinary incontinence isn't as common with radiation. I find that folks more have trouble emptying their bladders, or sort of what we call irritative voiding symptoms. So frequency, urgency with radiation, and they usually happen during treatment and then get better with time. But then there's this window of 5 to 10 years later where some of those urinary symptoms can kind of resurface. And I find that folks can go into urinary retention years after getting radiation. Their erectile dysfunction slowly declines over time versus it being affected right out of the gates like at surgery. And then radiation cystitis is something that it happens to a lot of folks after radiation, but it can take 5 to 10 years before that happens. And those are these irritative voiding symptoms. Sometimes you see blood in your urine. It can be anything from a speck of blood to we can't stop the bleeding. And I think folks are sometimes shocked that, a decade after treatment this can happen, but that really is more of the time that it does occur. And so, the majority of patients have good outcomes following surgery or radiation with minimal long-term side effects. But for those folks that do develop these long-term side effects, it can have major implications on their overall quality of life and their daily function. So I just want to acknowledge that. So these are some of the physical side effects. We've touched on a few. I'm going to touch on a few more. So the biggest one is erectile dysfunction. I hope you guys were able to attend last night because I think it was probably more of a deep dive. into this. But the first line treatment we use are oral medications or the PDE5 inhibitors. Examples of brands: Viagra, Cialis, Levitra, Stendra. We don't really choose one over another, but they do have some difference in price. They're vasodilators. They force blood flow to erectile tissues and nerves. And the downside is that they're expensive. Medicare and Medicaid don't cover them. A lot of private insurances don't cover them. And they're not without their side effects: headaches, flushing, nasal stuffiness, lower blood pressure. And some folks, it's just too risky with their cardiac history to try them. You know, I have folks that years after treatment, they want to try this, and I'm always willing to try. But if it doesn't work, you know, one or two times, then I kind of say, don't waste your money on it. And not to say that it couldn't. I also have guys that are like, it doesn't work. And I'm like, well, tell me how you took it. And guys will say, oh, well, I ate a big steak, I had a glass of wine, I went and sat in front of the TV. And I'm like, well, you got to work with it a little bit more than that. So, I mean, it isn't you take a pill and you get an erection. Like, you still have to have libido, you still have to have stimulation. And so I think some guys expect you just pop a pill and it's gonna work, but it does require some work on your part. You know, some people aren't willing to try more than medications, and so I never push. I give folks information about next steps, but I never push it. Some guys draw the line. If a pill doesn't work, then they're not willing to go farther than that, and that's okay. But there is injection therapy, which is, unlike taking the pills, it's pretty quick. I mean, it happens within 10 minutes of giving yourself a shot with a small insulin needle. You can start it as early as 6 weeks post-surgery. It can be done anytime during radiation or anytime after. So even guys that have 5-10 years out, haven't had erections in years and years and years, they suddenly decide they want to try it, you can. It's usually done with a urologist as a test dose in the office. But there's really no harm to try it. But again, guys draw the line. They say, if I have to give myself a shot, I don't want to do that. And that's okay too. But they come in 3 different kinds of shots. So there's Trimix, which is 3 drugs, Bimix, which is 2 drugs, and then Alprostadil, which is 1 drug. And depending on your urologist, they may try 1, they may try 2. These also have side effects, and one is pain, and that isn't just injection site pain from giving yourself a shot, but guys describe it like a headache in my penis. Some folks experience and some don't. And that's kind of the beauty of the test dose. You find out if that's going to happen to you or not. And then another possible side effect is the long-lasting erection or priapism, which we try to manage at home first with Sudafed, which is over the counter. But if that doesn't work, then you have to go into the hospital, and it's more of an invasive procedure to get that to go down, which can be scary. So don't borrow a vial from your friend and try it at home on your own. You really should do a test dose with a urologist or urology nurse or nurse practitioner and work on titrating your dose so that it's most safe. And then there's also pumps, vacuum erection device, many of you may have heard of, which is like an external pump. And there's also a bigger surgery, a penile implant prosthesis, also known as an IPP or inflatable penile prosthesis. You know, a pump probably costs a good one, a couple $100, maybe between $100 and $200. And then a surgery is obviously a big undertaking with a big recovery. And, you know, many folks aren't surgical candidates, whether that be from diabetes, their A1C is too high, they have other comorbid conditions that urologists say it's too risky to do this surgery with you. I typically tell folks who've had a prostatectomy, wait 2 years before having a big surgery for erectile dysfunction, so you kind of see where you land. But some men choose to go this route. And then I just want to put a blip in here that, you know, penetration is not the only way to be intimate with your partner. Many couples find other ways to share love, affection, express themselves. And so I also think it's important to note that no matter what treatment you do, radiation, surgery, it's not going to take away a man's ability to have a climax or an orgasm. So you don't have to have an erection to be able to have a climax. And I don't think not all men or couples know that. And so, again, treatment doesn't take away your ability to have an orgasm, and you don't have to have an orgasm with an erection. You don't have to have an erection to have an orgasm. So moving on to urinary incontinence, just want to touch on 2 surgeries we do for urinary incontinence. One's a male sling, and the other is an artificial urinary sphincter. The AUS, or the sphincter, is definitely a bigger surgery. There's like a cuff that stays around the urethra, and then there's a button in the scrotum that opens that cuff so you can void, and then it closes back up. I see a lot of men with a pretty high satisfaction rate that gets this surgery done, but it is painful, it's a big surgery, and it is a recovery. And then I tell folks, it's best to have like a urodynamic study with a urologist to really know if the male sling is appropriate, because it's not going to fix incontinence for every man. It sort of depends on what your issues are. And then I just want to touch on bowel and bladder dysfunction, which is usually more radiation side effects. It can vary anywhere from being minimally bothersome to totally debilitating. And so I really see more of a range in radiation than I do in surgery. And again, most folks who do radiation have good outcomes, but I see folks that have sort of urinary frequency and urgency during radiation treatment, and sometimes there's behavioral modifications we can do for that. So I tell folks, when guys say, I'm getting up 4 times at night to urinate, I'm going to say, well, when do you cut off your fluid intake at night? 10 p.m. And then so I tell folks, try to cut off your fluids earlier. Try to get your water in during the day. And then other behavioral medications are, just knowing that you're going to have to wear an extra pad when you go to the gym, lift something, mow the lawn. Other guys use a penile clamp or a Cunningham clamp, which I had one patient describe as a clothespin for their penis. But for some men, short term, I have guys that I just mow the lawn with it, or I just go work out with it, and then you take it off. It's not something that you wear all day long. It's just that you use for a few hours. And you can talk to your urologist about that. They come in different sizes. So that is another thing that we use for urination. And then there's oral medications. So some guys use overactive bladder medications to decrease their urinary frequency. Other men take anti-diarrhea medications if you've got bowel issues after radiation. You can also avoid alcohol, caffeine. Some of those are bladder irritants. And then spicy foods can sometimes irritate folks' bowels. And then a few men do have to do catheterization or wear an indwelling Foley catheter or have a suprapubic tube after treatment. And in some really rare cases, they have to have bowel or bladder removed. So moving on to hot flashes. This is kind of the biggest side effect I see with hormone therapy or androgen deprivation therapy, brand names like Lupron or Eligard. I usually tell men that the first shot is the worst. So when we're taking your testosterone from normal to 0, that's usually when you're getting the most hot flashes. And we usually give 3-month shots. That's just sort of the most common. It can also be given 1-month shot or 6-month shots. But usually that first one is the worst, and men complain about hot flashes. It can really vary. I have some patients that don't have hot flashes at all, and I have some patients that say they have multiple hot flashes an hour. And I can't predict who's going to have these horrible hot flashes and who's going to not. I tell people, you can make some lifestyle changes. Guys say sleeping with a fan at night helps. And then when guys come in and they're really, saying this is so awful, I say, is it bad enough that you'd want to take another medication for it? And if that's the case, there's 3 that I like to use. Effexor is an antidepressant. It's used at lower levels for hot flashes. It's pretty good. Megace is an appetite stimulant that's used at lower doses also for hot flashes twice a day. And then Neurontin or gabapentin is a drug that guys use for neuropathy. Sometimes your diabetic folks take it, but it can be used at bedtime for hot flashes. And then fatigue. It's super common with androgen deprivation therapy or other prostate cancer medications, enzalutamide or Xtandi. It's pretty common with that. Some guys say, I'm able to take a 30-minute power nap in the afternoon and get through my day. But really the only thing you can do other than a good night's sleep is exercise. So it's counterintuitive. It's the last thing you want to do when you're tired, but it's really the only thing you can do to give yourself energy. And so I tell my patients, when you get in that afternoon slump, go try to take a brisk 20-minute walk. It will give you energy afterwards. But sometimes we also have to use medications for this. So we sometimes use steroids like prednisone for folks who have significant fatigue. We sometimes have to reduce their dose on their prostate cancer medications. And then sometimes we use stimulant drugs like Adderall even for some folks. Cognitive function. A lot of guys tell me they just don't feel as smart on hormone therapy. They feel like this brain fog, which is very real. When testosterone is low, I think folks don't think as clearly. And so guys say they have some short-term memory issues, difficulty concentrating. I don't have a whole lot of great interventions for this, but I tell people make lists, keep your keys in your phone in the same place, use pill counters so you remember if you've taken your medications or not, sort of basic memory things. But I even have had folks who have stopped treatment based on how bad their brain fog was. So it is a real side effect that a lot of men deal with. And then I think also the mental load of having prostate cancer can take its toll. Another physical side effect we manage a lot in prostate cancer is nausea, and it can be from treatment. These are some of the medications I like to use. Zofran's my favorite, especially the formula that dissolves underneath the tongue because it works really quickly. Compazine is a good anti-nausea med. When Zofran and Compazine don't work, I use Zyprexa, which is an antipsychotic, but it's used off-label. It's great for nausea. And then Ativan is an anti-anxiety drug that we sometimes use for nausea. I don't have a whole lot of good alternative remedies, but some folks say like ginger chews or ginger foods help with nausea. And then sometimes we use like Prilosec or Pepcid because some guys say they're nauseous, but it really is kind of more like a reflux feeling. And this is a joke. It's a picture of a pharmacist with all these pills, and he's basically saying, this one in turn will cause side effects of nausea, for which I'm giving you Trilodol, which will induce temporary blindness, which I'll counteract with. So it just kind of shows, there's only so much we can do to help with side effects, but we kind of get in this loop where you have a side effect, we throw another medication at it who also has side effects. So you really have to weigh risk and benefit when choosing to take a medication for a side effect. And so that's why I ask guys, I'm like, is this side effect bad enough that you want to try another medication for it? And that kind of helps them qualify how bad it is and if they're willing to try something. Another big physical side effect we see is weight gain or loss of muscle mass, and that's definitely due to hormone therapy lowering testosterone levels. So guys with lower testosterone levels will say their arms and legs feel smaller, their belly feels bigger, which is very real. You definitely lose muscle mass on hormone therapy, and your metabolism changes, and so you store more belly fat. It can also be from fatigue, from a lack of physical activity, and it can be from physical activity limitations. So maybe there's cancer in hip, or you've got a bad knee or a bad shoulder. And then sometimes the steroids that we give with prostate cancer treatment can cause folks to gain weight. And so how do we combat that? Really, just exercise and nutrition. I tell folks, particularly for the loss of muscle mass, to do weight-bearing exercises like swimming, elliptical, light weights. Some cardio will also be beneficial. And then I tell folks to focus on nutrition. I rarely tell my prostate cancer patients to limit caloric intake. I only tell folks to eat less, like if they've had a 30-pound weight gain in a 3-month span. I really tell guys to more focus on healthy eating. So what's heart healthy is prostate cancer healthy. So increase fruits and vegetables, decrease carbs. I have guys that come in and say, I'm going to cut all sugar out. And, I think a lot of people try that and think that's going to be helpful, but we really don't have the basic science research to support that. So I tell people it's okay to have sweets. Just watch what you eat and try to make healthy choices. Bone loss, another physical side effect. So anyone who's on long-term androgen deprivation therapy should be taking calcium and vitamin D. I put the milligrams here. Some guys choose to only take vitamin D, especially if their diet is high in calcium, like milk, cheese, yogurt. Other folks take both if you're on long-term androgen deprivation therapy, because as your testosterone levels stay low, it can decrease your bone strength. And I also recommend anyone on long-term hormone therapy get a DEXA scan or a bone density test every 2 to 3 years. That's usually dictated by insurance, but it will get paid for every 2 to 3 years. Also recommend weight-bearing exercises, same as they recommend for women, postmenopausal. Weight-bearing exercises will decrease bone loss. And then based on those DEXA scans or the bone density test, if guys have osteoporosis or they're at a higher risk of fracture, or maybe they've had a fracture, we give these extra drugs, Exgeva, Prolia, Zometa, to help build bone strength. And anyone who has cancer that has metastasized to bone and is castrate resistant, you would also qualify for these extra bone strengthener drugs. So now I'm going to spend the rest of the talk talking about emotions. And there's a lot. There's a lot of emotional side effects of prostate cancer. We've talked a little bit about loss of control when guys are first diagnosed, but all of these other emotions I've listed here are going to be some that I'll also touch on. So the first one is depression. Side effects of medication, hormone therapy, lowering testosterone levels can definitely have mood changes. And I'm not saying Lupron causes depression, but I'm saying that it can sort of jumpstart depression. Along with those feelings of loss of control, fear of the unknown, PSA anxiety, worrying about your family or your spouse, feeling isolated. When guys come in, I have very few patients that come in and say, I'm depressed. It's really picking up on little things, like them saying, they're not enjoying things that they used to, they're not getting out as much. I'll have spouses come in and say, I think they're depressed, to which the patient usually says, no, I'm not. And so I think it's something that's underdiagnosed in prostate cancer, and I think that when you're actually depressed, you don't have the insight to go to your doctor and say that. It's kind of hard to figure out and recognize. And so many times I'll bring it up and I'll specifically say, how's your mood? And sort of go from there. But I would say, a lot of my prostate cancer patients show clinical signs of depression. So what can we do about it? Counseling, both marital, family, individual counseling, support groups. And then I'm very pro-medication, antidepressants for those that need it. And again, men are resistant to add on more oral medications, and I get that, but I try to view it in a way that you can go on an antidepressant for 3 months, 6 months, a year. It's not something that you have to stay on for the rest of your life. You can try it. If you don't like how it makes you feel, you can wean off of it. But I do offer it to my patients when I think they need to try it. And I try to lower the stigma that an antidepressant is a crutch. I think many men feel like, oh, it's not in my personality to be depressed, or it's not in my personality to rely on medications to make me feel happy. And I also tell folks, like, it's not like you take this pill and you're going to be singing in the shower tomorrow. It's very subtle. And most of the time, patients' partners or spouses will say, I can tell a difference, but a patient may not be able to really tell a difference when they're on antidepressants. Sometimes they feel a difference when they try to go off. But I would say in my own personal practice, especially with advanced prostate cancer, maybe upwards of 30 to 50% of my patients are on an antidepressant. And it's also something that if you don't feel comfortable talking to your urologist or your medical oncologist about, you could also talk to your primary care provider about. But I'm very pro medications in some settings for folks that I think need it. Other ways to deal with depression that aren't using medicine or relying on your family or friends, sharing your story, and advocating. Anger. This is a big one that I see with men with prostate cancer, which is understandable. A lot of men are very angry at the time of their diagnosis. Anger can come up at any time during treatment or survivorship. I mean, cancer changes your plans, it changes your routine, and folks get mad about that, and understandably. I also find that patients get angry about the way their family and friends react. It can range from, I'm mad my friends aren't saying anything, to I'm mad when my friends say something. So it really, either way, can evoke feelings of anger as you see how others are reacting to your cancer. And then I see men that become mad at God or the universe. And sometimes anger presents more like irritability, and people don't always recognize it as the feeling of anger. And so there's unhealthy ways of dealing with anger. I think one of the big ones is avoiding expressing emotion. I think that's one of the most unhealthy ways to deal with anger, because it's never going to go away if you avoid it. Other unhealthy ways are hurting yourself or others, or abusing alcohol or drugs. These are all common ways, unhealthy ways that people deal with anger. So when I think about what are healthy ways we can deal with anger, talking about it, physical activity, even complementary therapy like massage, relaxation, meditation, doing something that you enjoy and that relaxes you can help with anger. And then also counseling. I mean, people don't just go to counseling for depression. You can also go to counseling for anger. And then it's sort of another emotional side effect that I see is prostate cancer affects your relationships with others. It affects your relationship with your partner or your spouse because you feel like you can't be physically intimate. But even emotional intimacy is sometimes difficult for men with prostate cancer, opening up to their spouse, talking to their spouse about it. I see spouses trying to push their partner to talk about it and kind of coming up with dead ends. And then I see, single patients, those that are recently divorced or out of a relationship. They feel like they can't date or meet new people because then they have to explain the physical side effects, explain their history with prostate cancer. And then I just want to recognize that there's definitely a health disparity in prostate cancer sexual minority care. Gay men say that they're treated as if they're heterosexual, and patients also say they feel like they can't disclose their sexuality for fear of rejection or stigma. And then it also affects patients' relationships with their children, their parents. I find a lot of folks don't want their kids to know or don't want their elderly parents to know or worry, so they don't tell them or they minimize. And it can also affect your relationships at work. Some folks want their work to know they have cancer as they're trying to go through treatment. Other folks don't want their work to know because they don't want to be treated differently. Guilt. This is a huge emotion that I see with prostate cancer. And it's one that's often hard to get to the bottom of. I find men have a lot of guilt because they didn't notice symptoms or they didn't see a doctor sooner. And especially in the pandemic, where I think access to care was limited, folks may have skipped a primary care doctor visit, or their urology office said, we can't see you this month, come back in 6 months. And so I see a lot of guys that are really focused on, the fact that they didn't go to the doctor or that they didn't have access to the doctor in the pandemic, which they think negatively, affected their prostate cancer outcome. And I find guys feel the burden of guilt because they're worried they're going to be a burden to their family now or in the future. And then I see a lot of treatment guilt. I see folks feeling guilty because the treatment you chose or the treatment you received didn't work in the way you had hoped as far as side effects or cancer goes. And some of that I see displaced on the physicians that treated them, anger that their surgery didn't work or their cancer came back. And then I also see folks that feel guilt because they think the choices that they made or the lifestyle decisions that they made caused them to get cancer. And so they sort of rationalize with themselves, like, I deserve this, or it's something that I did in my past, and that's why I got it. And these feelings can also include embarrassment or shame due to the organ you have cancer in. So again, not something that you can control, but that guys report feeling embarrassed or shameful about. There's also survivor guilt. There's this guilt that folks who survived, but others didn't. And that can really sit with folks. And then there's this family, friends, and caregiver guilt. So they feel guilty because they're healthy, and someone they love or care for has cancer, and you can't make them healthier. And then they feel bad that they feel stressed or sad because they're not even the ones with cancer. And so guilt is a very real emotion in prostate cancer. And when we think about guilt or how to cope with it, I try to frame it where I tell folks, you're responsible for a lot of things in your life, but you are not responsible for getting cancer. And I try to give people permission to sort of let go of that personal feeling of responsibility or their caregiver. And because, and I tell people, repeat after me, cancer is not my fault or someone else's. Because when you feel guilty about events that are outside of your control and you can't let go of it, it can lead to clinical depression. And I think, it's okay to feel guilty. It's okay for that feeling to come and go, but you have to talk about it. You should utilize support groups, whether it's in person or virtual. And then you got to try to focus on things that make you feel good or happy or thankful to sort of let go of some of that burden of guilt you might be holding. And you got to find ways to express your emotions in other ways: writing, art, music, hobbies, travel. You got to do things that make you feel good. Worry is another common emotional side effect. And I find that there's triggers for this, usually like appointment visits. My guys walk into their appointments, their blood pressure's 180 over 100. They're like, I swear it's not like this at home. I don't want to be here. I don't like coming to the cancer center. And so I think, worry and appointment visits really can have physical effects on men. Also, if you develop a symptom that was similar to one when you were diagnosed, if you were diagnosed after you had hip pain and you get a hip pain, it cascades into this worry of my cancer is back or my cancer is getting worse. Some men deal with anniversaries, which also trigger worry, even if they're 1 year out or 2 years out. Even sometimes just reminding themselves of that makes them more worried. And then worry can be triggered by, someone you love is diagnosed with prostate cancer. I know I'm a little over time. I'm going to spend about 5 more minutes going through these last few things. Anxiety about cancer returning is a real emotion that men with prostate cancer live with. And I found this quote from cancer.net. Although you cannot control whether the cancer returns, you can control how much the fear of recurrence affects your life. And so I think you got to think about that. You can't let the fear affect the way you're living. And then obviously checking PSAs induce anxiety, and then scan anxiety. I used to schedule my scans a week before patient visits, so there'd be 2 to 3 days to get the scan back, a couple of days for me to take a look at it, and then they're in. But the longer patients go between having a scan and having their doctor visit, the more anxiety they're going to feel. And so I would encourage you, if you have to have a scan, schedule it 2 to 3 days before a doctor visit, so there's not time in there for you to review the results, look at them, worry about them, and wonder what your results are. And so when we think about prostate cancer, I think we have to think about it as a chronic disease. Whether your cancer is not curable or you're going to be on lifelong surveillance, it's never going to go away. It's always going to be in the back of your mind. And we sort of have to treat it, and not to diminish the seriousness of prostate cancer, but I think we have to treat it like it's high blood pressure or diabetes, and that it's something you're going to be living with, you're going to be monitoring as a lifelong thing. Real quick, other things you can do, advanced care planning. It's a lot easier to talk about what you want the end of your life to look at when it's not the end of your life. And so I think we as healthcare providers need to be better about giving patients information about this, making these forms available, and putting it in the hands of folks to think about early in their diagnosis. Like, have you thought about what you want your healthcare wishes to look like, and who's going to make financial decisions for you, and who's going to make healthcare decisions for you if you can't make them for yourself. I just want to talk briefly about religion or spirituality. I find that folks who are religious do cling to their religions more after diagnosis and through treatment, because you ask these big questions. Why did this happen to me? What is the purpose of my life? And I think ministers, pastors, priests, rabbis, religious leaders can sort of help us grapple with these big questions about life and death and existence, and how do we create legacies and find purpose. I also find folks that were not religious before their diagnosis, then they become interested in religion after their diagnosis as they think about what's life have for me after this. I think social work is also incredibly helpful in sort of helping people create legacies and things to leave behind, mementos to help think about leaving legacy and leaving things behind for your loved ones. And then, a religious community can really help in surrounding folks with positive support, prayer, meals. It can also be helpful for caregivers. And then trying to end on a more positive note, laughter really is the best medicine. It has positive health benefits. It helps the mind. It boosts mood. It can decrease depression and anxiety. And so I think I encourage patients, what makes you laugh? What makes you happy? My husband likes watching what I think are dumb movies that are silly. And if that's what does it for you, you've got to choose things in your life that make you laugh and that make you happy. And if it's, silly movies, it might be nature. And you've got to really examine what gets you through your day. And I find that for some folks, it's work. A lot of people also find a lot of meaning and joy in their work, and they don't want to retire or stop working, and that's okay too. Other folks say, I want to enjoy my life and not work. And so I see, honestly, 50-50 sort of split in that. And so other ways to find meaning, guys say a lot of times their cancer diagnosis is like a wake-up call. They may reach out for more spiritual support, journaling, sharing your story. How do you help others with cancer? You can be on research studies, you're here, you can be an advocate. These are all ways to sort of turn something negative into something positive. And I'll put my blip in for ZERO. You guys are already doing that. But ZERO offers a ton of support in your survivorship journey. Use the resources and allow them to sort of help you in this journey. And these are some online sources outside of ZERO that I think are helpful for cancer survivorship. So since I ran over time, I won't take questions, but I will hang around the stage if anybody wants to come and ask questions or give comments. But thanks for your time. Thanks for being here. And thanks for doing what you're doing to share your story and network with other folks in the prostate cancer community. So thank you.